You're listening to Fast Facts Perio Edition. And now, here's your host, Katrina Sanders.
Hello, and welcome to Fast Facts Perio Edition. I'm back for part 2 with the amazing Dr. William Levine, my periodontal friend, all the way on the other side of the world in Israel. Dr. Levine, welcome back to Fast Facts Perio Edition. And thank you so much for being here.
Well, Katrina, thank you for inviting me, and it's a pleasure.
Oh my gosh. So for those of you who didn't join us for part 1, I'm going to ask you to pause, go back to last week's episode and check out part 1, where we get real geeky on all things inflammation, looking at the transition between that early onset acute inflammatory process and then what chronic inflammatory processes or disease actually looks like, how the body responds. Because now we're starting to really get down to the, pun intended, foundation of what it is we understand about periodontitis. And I think this is really critical because this is where we're starting to, I don't know about you, Dr. Levine, but it seems like every other day there is a new research article that's come out that says, now, this type of cancer has a biological plausibility, or at least a unidirectional link back to periodontitis. In many of these cases, we're seeing those bidirectional links. Parkinson's disease, Alzheimer's disease. It is so robust. And for so long, we've been looking at the secondary pathway to the inflammatory process, which is the dumping of bacteria into our bloodstream and circulating through the body. And what we're missing inside of a lot of this research is that initial pathway, the inflammatory pathway, which is when the inflammatory process occurs in the oral cavity, and we see that transition from acute inflammation into chronic inflammation. So now we're starting to see, various inflammatory cytokines, C-reactive proteins from the liver, all of those components start to become critical aspects to this process. But one piece that I think we're missing so much is that a lot of this inflammatory pathway, what we're seeing in the links between oral inflammation and systemic inflammation is the very fact that once the body in the oral cavity shifts into that chronic state, now the immune system is working in overdrive. Now it's like I always say this, the immune system is like a battery. So now you've got one more thing hooked up to that battery, right? When we move into chronic inflammation and it's draining. And what we're doing when we're looking at periodontal disease is truly observing the host's response, the inflammatory response to that dysbiotic biofilm. High concentrations of disease-producing microbiota, low concentrations of health-producing microbiota, and what actually happens on the playground when more naughty kids are there than there are the nice kids, right? And it really is that response that we're starting to crack open, not just in research, but how do we show up clinically? Now that we know, now that we understand, it's not just the bacteria. That's one piece of the puzzle. But the other pieces of the puzzle are, how is the body responding? And gosh, everybody responds differently to the inflammatory process, depending on your immune system, depending on, components like, do you have rheumatological conditions or autoimmune disorders? Are you a tobacco smoker? What does your mucosal membrane look like? Do you have a thin gingival biotype? All of these things create this cascade, as it were, of how each patient is going to show up. And yet here we are, right? You're a periodontist practicing in Israel. You've got 30 years of practice under your belt in Israel as a periodontist in a large perio, pros, and oral medicine clinic. And we still go back to the basics of probing a patient, eliciting a bleeding response. And unfortunately, some of those basics are those gold standards that we learned in dental and dental hygiene school that perhaps now we need to start thinking about differently, right? So we've got a fast fact that kind of guides us into this direction. So let's chat about our fast fact for this part 2 episode, looking at what has been the gold standard and where have we been going wrong?
So it's an interesting question, and it's I think it's something that we had a simple solution that's based on data that's very, very old. We had a model that we all like to plug into because it was easy to explain to other people. The model was, you have an infection, it's causing destruction in your body. And if we clear up the infection, you will have better health. Now, it's true to a certain extent, but what we're missing is that juxtaposition. Infections by themselves, especially external ones, are not causing the problem. What's causing the problem here is the failure of our body to control that infection, which it's designed to do, maybe because it's been there for too long, maybe because there's some flaws in our immune system, maybe like you were saying, the patient is a tobacco smoker, maybe his resistance is low that time, or maybe it's just been there for too long and the inflammatory process went into overdrive, like we all see whenever we use our computer for too long and it starts humming and singing to us.
So I'm sorry, I want to interrupt here.
Yeah.
So what you're saying is technically the body should be well prepared if it comes in contact with bacteria. Our body should be prepared to handle that.
Correct.
And
it is.
And it is.
Yes.
So when we get into a state of periodontitis, what we're really saying is this is the body's failure to fully control what's the biofilm. And so our response, our gold standard has been, I'm going to take something that has a cutting edge, I'm going to shove it under the gum tissues, and I'm going to scrape it, right? Isn't that what that's been the whole thought process this whole time, right?
Yes, but on the other hand, we all know scaling and root planing works. I'm talking about a bit of an earlier stage. You've described it perfectly. We have a bacterial layer that's formed there. Our body is fighting against it, but because it's there. Let's say a patient picks up a toothbrush and cleans that off. That inflammatory response will disappear.
Okay.
If it's an early stage inflammation, that reactive stage, you can control that by simple plaque removal. It's when it switches over and you're now in that reactive stage where it's not only it's no longer controlling it and it becomes chronic, that's when you'll start to see destruction. When that happens, you can't just brush that away. You need to go under the gums and remove those bacteria. So you really do need to do that despite all our other advancements in the field. But once you've done that, you're still at high risk for problems because our mouths are toxic. Our mouths are filled with bacteria. We need that. They thrive in there. In fact, our entire digestive tract from the lips through the anus is basically filled with bacteria. We actually carry in that tract, on the average person, 2 kilograms of bacteria.
That's amazing. So first of all, we should call this episode From the Lips to the Anus, because I just
I don't know if you're aware of this, but there's a very well-known camera that's used to do colonoscopies. You swallow it, and then the computer reads the camera vision images. And the pill that you swallow, which has the camera inside, is called M2A. Mouth to anus.
Mouth to anus. I love that. So this is unbelievable because again, when we talk about perio, I mean, oftentimes, we're talking about what happens once the patient has periodontitis, right? That's when we start to get really involved in this. And we're talking about reverse engineering this and saying the body is designed to protect itself. We have to start thinking about how we support how that immune system shows up. And a critical layer of that is looking at, right, how we utilize the tools in our arsenal to help support our patients in that. Is that correct?
It's correct. And the truth is that you went farther afield than I have. And I love it because I think you're right. In other words, let's take this on a World Health approach. Okay, the child is growing. Children are immune to everything. They're going to grow up, but at a certain point, which we don't know the exact age, assuming that it's not a genetic predisposition to early onset or aggressive periodontitis, let's assume it's just standard chronic adult periodontitis. At a certain point in that child's age, we should be educating these children to stop thinking about bacteria and start about caries and start thinking about gum health.
That's
and
right.
At that point, we should put them on a regimen that is mild enough to protect them when they don't have disease, but not too aggressive so that we treat them as if they're patients, because they don't need to be patients. They need to just be managed. And you could probably prevent, I'm just taking a guess because there's no data to support this, but 70% of periodontal patients could have been prevented.
You're spot on. You're spot on. I just want to share one. Well, but this is really important because you're right. It begins with, oh, we're going to brush the sugar bugs off your teeth. And, those sugar bugs like ice cream. And we're so focused on the sugar bugs and the sugar bugs and the sugar bugs. When does that transition happen? Right.
Right.
When do we, and the thing is, dentistry doesn't know, right? I'm a perio hygienist here in Phoenix. I get asked all the time, when should we start? Like, at what age do you probe a patient? And you're going to get different answers across the board on that. So if we don't even know when to probe.
If you asked yourself now, what age would you start? What would your answer? Because there is data to support the fact that by the age of 35, 50% of these have significant periodontal disease.
Have periodontitis
which means
already.
It started early.
That's right.
It means that we're talking about 28, 27, give or take, maybe even younger. So
we're talking about 90% of our children between the ages of 10 and 17 have some form of oral inflammation in their mouth. So we're talking about the precursor here, right? Yeah. That it starts when they're that young. So my response was always, the moment that those adult teeth show up, you're probing them. And as a faculty member, that's what we would teach. Now, how does that show up inside of the reality? And this is really what our fast fact is about today, is what is it that we know and how does that actually show up inside of our clinical care? The way it shows up is usually around probably age 18, we're periodontally probing these patients. But the important piece inside of this is when we're doing this relatively new procedure, perhaps for this patient at 18 years old, are we having the conversation about what oral inflammation is? Because by the way, before they were 18, most of them went through puberty. Most of them had some sort of an inflammatory condition probably associated with their puberty. Most of them probably had a nutritional deficiency because, at least in America, most teenagers are extremely deficient, probably in like vitamin C, at a minimum vitamin D for most, particularly young women. Young women now are taking oral contraceptives. I mean, we have all of these sources of inflammation already. When does that conversation start? And then ultimately, how does that conversation start? So I love what you're saying, because really, we have to start thinking about this differently. How do we support the oral immune system while this inflammatory process is in the reversible stage of the disease process? And how do we do that in a way that doesn't feel like we just gave the patient a systemic antibiotic, which we know systemic antibiotics just wipe everything out. So how do we change that so that we are helping to protect our patients, but we're not killing the health producing bacteria along the way?
So that's really something that I gave a lot of thought to. Although the first part we discussed is really, it's an educational system. And I think you, as particularly as a faculty member, you're the people who need to lead these charges, saying, how do we change this educational forum? In other words, shifting the children over, or shifting young adults really over to thinking about gum health, because, we all try to do good things to this world during our lives. And one day I just spoke to myself, I'm not a cardiac surgeon. I don't save people's lives, but I do make people's lives better. And sometimes we take it for granted, but I realized, our teeth are so critical to our everyday function. If you think about it, it's your smile, which is often your first hello to a patient or to a person or to anybody or to your children or grandchildren. It's also your speech. You can't elocute properly if you don't have proper teeth, and certainly not teeth that are healthy. And the third thing is eating. I mean, we spend so much time preparing food, talking about food, and enjoying food. If you don't have your teeth, you are basically going to become relatively dysfunctional. And our replacement systems work, but they're not natural. And we want to keep the natural. So that was a plug for all of us. But back to what you were saying, and back to what I think we basically grew up in an era, like you said earlier, saying, okay, there's too many bacteria, let's just kill them. So, and systemic antibiotics were often recommended for acute cases. But more than that, we know that we're dependent on a partnership with our patients.
That's right.
We know that we can make them better with routine care, but if they don't brush their teeth and maintain the home care at home, we're sort of wasting our time. And if they do a great job and we do a poor job, we're wrong. But I'm not talking about that aspect. I'm talking about we need to have the patients being able to keep their gums healthy in an easy and simple to use way. So what did we give them? Years ago, we gave them alcohol-based mouth rinses.
Absolutely.
These dry out the gums.
Put alcohol on it. It's a
tissue.
solution.
I'm glad we didn't give them bleach, although there are, yeah, exactly. We're not talking about it, but we were close to that.
Mm-hmm.
So what we really, and chlorhexidine was in a sense a wonder drug in its ability to kill bacteria. But frankly, all of us here know that when you see that chlorhexidine stain post-patient using it, it's a disaster. First of all, you've killed the bacteria and you can only use it short term because it's not getting under your gums. The maximum penetration of that chlorhexidine under your gums is 1.5 millimeters to 2 millimeters. After that, you're not having any benefit. So you're not killing the toxic bacteria. All you're killing is the bacteria that they didn't brush. Okay, that's important, but it's not enough. But the chlorhexidine stain is so toxic, it's so unpleasant, it's so unsightly that it's a disaster. And forget the change of taste. I mean, that's another killer. So chlorhexidine is a very, very efficient bad drug. Okay. Now,
and that's just what it does to the bacteria, right? But what does it do to our own bodily system? What does it do to our own immune system?
Well, interestingly enough, if you just take a change of pace, our oral inflammation is a wound. It's a classic wound. Mm-hmm. You can put chlorhexidine on a wound and it helps clean the bacteria. But the reality is, number one, it's toxic to fibroblasts. It's toxic to endothelial cells. It's toxic to all those cells that you want to keep healthy. And actually, interestingly enough, our bodies can actually handle some minor amounts of bacteria. And if you look at the chronic wound data, which I spent a lot of time analyzing, killing bacteria does not help wounds heal faster unless they're acutely infected. But assuming a normal wound, if it gets exposed to bacteria, it's okay. The body can handle it. It really can, as long as you're normally healthy and not suffering from a disease.
Immunocompromised, sure.
Exactly. But otherwise, you can handle it. And giving antibiotics or giving topical or it does not help speed that wound healing up. And it doesn't in periodontal disease either. You get a short-term benefit, and then it's going to be static. So we need to do something that will both kill bacteria, particularly the toxic bacteria, and also make those gums stronger and reduce the inflammatory effect. So, and also this has to be perfectly safe. You can't have something that the patient can't take long-term.
Right.
So we went into when we worked on this project, we said, okay, let's use natural botanicals that have a very long history of safety. We define safety by their ability to digest over 1 gram a day, which is an enormous amount of material, 1 gram a day into their system systemically and not have any toxic effects after many years of use.
Wow.
Okay. Then what we did was we broke those plants apart and said, okay, what's active in it? What's reducing bacteria? What's promoting tissue healing so we can strengthen the gums, and what's reducing inflammation, and how is it working? Because it's very important to know how it works so that you can know what situations to use it in. So by combining these and creating finding and then generating a synergistic effect between the three components that we used, and just to go back over them, we use Sambucus nigra, which is elderberry. We use Echinacea purpurea, which is you all know it's known as an immune booster, but again, we don't really use it for that purpose. And we use Centella asiatica, which is a known wound healing agent in Europe. But we know that all of these have been ingested in large quantities, and we're using them topically at a very, very low dose, And basically, rinsing with that twice a day does something completely different. I want you to think about this. A normal antibacterial rinse, we call them swish and kills, right? And they're killing bacteria that they come into contact with, but they're not coming into contact with the worst bacteria that are under the gums. We have designed this project so that the rinse will actually penetrate through your gums. And we actually tested the biomarkers inside the pocket. And we would have them rinse and then test biomarkers inside the pocket. And a day later, the inflammatory biomarkers for disease, neutrophil activity, and all those kinds of things are no longer there. They're significantly reduced. In fact, we did a very interesting experiment, which we published, but imagine if you did not scale in root plane. You have an infected pocket, but you did not scale in root planing, but you applied a topical antibacterial agent. What would happen? You'd kill the superficial bacteria.
That's right.
But would you have any impact in the bacterial components inside the pocket? Very minimally. So what we did was we used this rinse, this combination rinse of natural products, and we had them rinse with it with acute periimplantitis, which is probably the hardest kind of infection
Right.
to. And we sampled the bacterial colonies with the probes inside, and on an ongoing basis, we had a 35% reduction just from external rinsing of the bacteria inside the periimplantitis in the pocket.
Wow.
And that's what you need to do. You need to go, we can't have home care that goes top down. We have to go right through the tissue and target that area. So for me, listen, patients buy this. They don't get it for free. If we make a mistake in the office and we have a shortage or something like that, patients are angry at us. They're clamoring for it. People feel the difference. People feel the reduction in bleeding. People feel the reduction of the inflammation. It's a game changer because we're able to go into the tissue, change the nature of the tissue, reduce the bacteria in the pocket and outside the pocket. So for me, it's been a lot of fun.
Oh, that's amazing. I love this because, we talked about this during part one. It seems as though in the United States, some of the opportunities that patients are asking for are in the plant-based area. We are getting patients that want a more natural approach. And we do recognize that there are healing benefits, wound healing benefits to a lot of these plant-based, opportunities. But we're not taught about them in dental school. We're not taught about them in hygiene school. We're taught about those gold standard pieces. So it is incredible to start seeing, because we recognize that a plant-based medicament is actually not wildly new. It's new for us, but
Right.
Historically, I mean, Hippocrates' time, that was a common, medicament they would use is very plant-based. That's where we began to develop a lot of the pharmacological compounds that we have now. So recognizing the benefits to something that is natural, that doesn't break down our own immune system, that doesn't break down the very fibroblasts that are working to lay down brand new gorgeous collagen, working to help support how our body responds in a state of inflammation. It really is interesting to see. And I have such an appreciation for the incredible work that's happening overseas, because this is where we start to kind of borrow some of that research, looking stateside and saying, is this something that makes sense for us to be able to support our patients with? And I know that there's a lot that happens over in Europe, on that side of the world that really has been very innovative for us inside of looking at the level of care that we're providing in a very different way.
Yeah, I will caution though, we're taught a tremendous amount of information in basic science and disease progresses and all those kinds of things. And we often don't get a chance to use it efficiently in our clinical practice. So the two pieces of information I just wanted to share that I think are really important to the group, to our group. One, the hygienist has been, in a sense, forced into a role because of the lack of ability to treat inflammation, into where she cleans the teeth and looks at plaque levels, where in reality, she's trained to recognize disease, see disease, understand the process, and do more. So what ended up happening in our practice, when the hygienists began to use this, they changed. They changed because all of a sudden they began to think like inflammatory experts.
There you go.
They began to think like disease therapists and disease managers, and not hygienists.
The tooth scraper.
A terrible term for your group. Because you really need to be, you're therapists.
That's right.
You're a form of dental therapist, and you should be part of the team, not just cleaning people. And so they've changed, and we didn't change them. We didn't ask them to change. They changed because they realized what was happening. And for them, it was a wonderful expansion of their role. And in fact, I find them coming to me with suggestions all the time now, which I'm thrilled about.
Oh, I love that.
So, and argue with me about it, which is wonderful. It's wonderful. I like to, because these people have been treating patients for 20 years. They are entitled to their say at the table. So that's one thing. The second thing is that I think that, in a sense, it's a harder thing to explain. So we don't always have that opportunity to go through that process with the patient. But dentists often have a more shallow relationship with some of the patients than the hygienist who sees them on a regular basis. So for a hygienist, often they have the opportunity to really discuss this more and to really support this more and to really support the patient more. And I encourage the hygienist in our office, you're not on a system. If you feel you need to see that patient a second time in 2 or 3 weeks, just schedule it. Don't ask my permission. I trust you.
Ah,
And that's what you should be doing. You're therapists, and you're so well trained to do it, and you're underutilized, because of that. So
wow.
so it's a new way of thinking.
I love that. Thank you. And thank you for giving my audience a little peek into the world of what it means to be a periodontal hygienist. Ladies and gentlemen, hygienists out there, hygiene students out there, anybody listening, this is really what it feels like to work with a periodontist, because periodontists truly do believe in the work of, I'm changing the title. We're no longer dental hygienists. I've decided we're changing the title to oral healthcare practitioners, because that's exactly what we are. But I love that. And thank you so much, Dr. Levine, for sharing your wisdom, for giving us some of those insights on some of the amazing things that are coming down from our colleagues overseas that we will likely see begin to trickle into our clinical care, and for reminding us about how critical it is for us to look beyond scraping the tooth and really start to develop that intimate relationship with inflammation. Because you are spot on. We are inflammatory specialists. We are wound care specialists. And we are lifesavers when we truly take a look at how critical it is for us to control this inflammatory condition that is modifiable, that we absolutely can and should address. So thank you so much for joining us. If you want to check out more information about Dr. Levine, please check out the show notes. With that, thank you for joining me, Katrina Sanders, and Dr. William Levine. This has been another episode of Fast Facts Perio Edition with Katrina Sanders. Please feel free to reach me on Instagram at The Dental Hygienist or on my website, www.katrinasanders.com. Cheers.